microphone.
Yes, sir. Good evening, sir. My
Good
topic
evening.
for today is simulation in anesthesia training. Simulation in medical curriculum is recreating or imitating some part of clinical scenario for the purpose of training or evaluation. It became an integral part of resident education and research. It comes from low fidelity to high fidelity models that mimic human responses in a realistic manner, extremely lifelike mannequin which generates electrocardiogram and has pulse, arch sounds, and an airway program for different degrees of obstruction. Anesthesia in general is compared to an aviation industry, like example pilots training. Users are the simulation is helpful in orientation to new procedures, exposure to uncommon clinical scenarios, and assessment of knowledge. Simulation accelerates skill acquisition and it helps in skill retention and decreases the extension of skills and helps in technical skills and also reinforces the non-technical skills such as leadership, teamwork, task management, decision making, and situational awareness. The components of simulation are initial debriefing, the actual simulation experience, and the debriefing. The debriefing is the chief component of the simulation, which is the first step in changing the clinical practice for better patient outcomes. It allows the trainee to understand the decision-making process. Simulation is an interactive and innovative educational tool that can build confidence and improve the clinical knowledge through practice and enhance the team performance. Anesthesia is a hands-on specialty which is a pioneer for introduction of simulation in medical education. Simulation provides a safe learning environment where anesthesiology residents and students can be taught, practiced, and evaluated on technical skills such as intubation and ventilation. And simulation in widespread use, it is helpful in crisis management training, and it also helps to experience clinical scenarios which are infrequent in clinical practice. For example, double lumen tubes and bronchial blockers for single lung isolation. Simulation also gives hands-on training to non-anesthesiologists where they are trained to help them. There are inherent limitations to teach in the operating room, like natural distractions that hamper the learning experience, and balance between the patient care and education should also be considered. And simulation provides a platform for training in a risk-free environment. And the first ever simulation model was Lardell's Rescue Hand, which is a simple model to teach the CPR. And the first true moderate high infidelity model is SIM-1, which is a lifelike prototype, which is an anatomically shaped chest that moved with breathing, with eyes blink and jaws open and closed, and the pupils dilated and constricted. There is also a software-based simulation available, that is, for example, Gasman software, which helps to explain the pharmacokinetics of anesthesia administration. There is also high fidelity mannequin simulators by Dr. David Gaba, who gave a comprehensive anesthesia simulation environment, which helped with the anesthesia crisis resource management training, which is a realistic and physical simulation system. And other examples are, there is Gainesville anesthesia stimulator developed by Gravinston, which is a very sophisticated simulator which imitates the breathing and also generates a pulse and electrocardiogram, and also a lung that follows the normal physiological calculations to consume and eliminate the gases accurately. There is also hidden sensors within the intact anesthesia machine which record the user's action and also helps in providing feedback accurately. And the current state of simulation in anesthesiology is based on the three categories, which is the mode of interaction. And mode of interaction is in the form of screen-based, hardware based or virtuality reality based, and the physiological model used, and they're used to teach the psychomotor and cognitive skills. And the other uses of simulation in usage are simulation is also helpful in airway management, especially in difficult airways and all. And also simulation is also helpful in teaching adult and pediatric regional anesthesia. And simulation is also helpful in obstetric anesthesia like epidural learning. And simulation is also helpful in cardiothoracic and vascular anesthesia, and also helps in teaching non-technical skills using simulation. Thank you, sir.
Have you ever attended a simulation workshop in any of the CMEs?
Yes, sir. In Adayar Cancer Institute, Onco Difficult Airway cut last year.
It was conducted recently.
Yes, sir.
Okay.
No, sir.
Okay.
Last year, not this year. Last year I went.
Last year you attended. Okay.
Yes, sir.
What did they teach you at the time?
It was a different difficult airway. All the FOBs and double lumen tube, the procedure of inserting and video laryngoscope, and different case discussions were also being done, sir. All the in general and how to manage, approach it. It was very helpful, sir.
One type of simulation training, airway management.
Yes,
what are the other simulation categories are present?
Categories, sir.
Or other topics which can be discussed as a simulation topic. Airway management is a common thing. Anticipated airway difficulty as well as unanticipated difficulty airway management is part of the training that you have to undergo. Supposing you start a case, let us say we discuss about an hypothetical situation. You have been asked to start a GA case. You have started the IV line, you are giving thiopentone or you are giving propofol. Nowadays, of course, thiopentone nobody uses, you give propofol, and there is a sudden drop in BP and pulse is not palpable. What will you do?
First we have to give enough fluids, sir. Then if
now,
at
what
all
are
it's
all
not...
the causes which can result in such a situation? First of all, before you think of the treatment, you must identify the cause, isn't it?
Yes, sir.
So what could be the cause for a patient suddenly collapsing with no pulse and not recordable BP after you have injected a drug like propofol?
Any anaphylactic allergic reactions?
Anaphylaxis, or you have injected the drug very fast and patient already had some cardiac issues, and it produces a very severe vasodilatation, and there is a hypotension and pulse is not palpable. Okay, so first thing in that situation, does it happen every day to you?
No, sir.
No. Have you seen any case like that in your 2 years, or now how many years you are in anesthesia so far?
Second year going to end, sir.
You are going to finish. Okay, so third year you are now in. So 2 years, have you seen a situation like that?
As of now, during induction
you have not seen. So this is a very rare situation. But if a situation like this is created in a simulation workshop or in a simulation lab, then you know how to manage it, isn't it? Because on the contrary, if it happens for the first time, you will be little nervous. You will be anxious, isn't it? Because something is wrong with the patient, and you will feel guilty that have I done anything wrong? But in simulation, it gives you the confidence that you can manage that situation because you have been trained in a non-risky environment where nothing can happen or go wrong to the patient. Okay, so that is another important thing. Anaphylaxis management is a very important part of simulation. Bronchospasm intraoperatively is another important simulation. Okay, Massive fluid loss or blood loss is another form of training in simulation. So, all the critical incidences that can happen during the anesthesia and surgery all can be taught in a risk-free environment, as you correctly said in the simulation workshop.
Yes, sir.
So these are all the things that have been taught to you. So they give you a clinical scenario and then ask you to manage that. And the development of very good mannequins, which almost look like a real patient. They can have a palpable pulse. They can have a saturation which can be responded from the fingertip. They can have a pupil reaction. They can have a noise produced during bronchospasm or stridor. So the development of such mannequins, which can almost 90% mimic like a normal patient, gives the added advantage of the students to learn it from the mannequins without causing any harm to the real patient when they go and start managing them. Okay, that is the idea of simulation. And so the simulation advantages are two things. One is technical skill improvement, like holding a laryngoscope, putting on an intubating a tube, or as you said, passing a double lumen tube or a fiber optic, which you don't do every day. All these things can be learned in a very calm atmosphere. The second is that non-technical skills. Okay, anesthesia non-technical skill, ANTS, as it's called in short form acronym, ANTS. ANTS is the short form there, which is again a management of a critical situation with the available persons that you have. Okay, where you have to take the leadership quality of giving the task to assigning the task to everyone, so that the crisis is met effectively to produce a good result without any damage to the patient. Okay, that is what is called the non-technical skill development, which also can be improved by doing or putting the students in the simulation lab or workshops. So we just go to discuss